So, hello everyone. Good evening, ladies and gentlemen, and thanks for joining us in the 10th Saudi Ophthalmology Society webinar, which is the second webinar of Saudi Glaucoma Group. Now, with the non-stop revolution in new glaucoma surgical procedures, we as glaucoma surgeons started to face more challenging complications, and we are continuously learning and building our skills and experience to manage these complications. Today, we will have together and we will share some of those challenging complications and the way our speakers used to manage them. We are having three of the most talented Saudi glaucoma surgeons. All of them have graduated from King Khalid Eye Specialist Hospital Fellowship Program. And I personally had the pleasure to work with them and supervise them. Tonight, we are having AAA battery speakers. We have Ali, Ahmed, and Ala all start with A. So I'm expecting a very powerful interacting webinar. So without further ado, please welcome me to join me to welcome the first speaker, Dr. Ali Al-Bishri, who is a glaucoma and cataract consultant at King Khalid Eye Specialist Hospital. Dr. Ali is going to speak about Ahmed implant challenges and complications. Ali, please go ahead.
Thank you very much, Dr. Ahoud. Thank you for being the moderator of this session, and special thanks to the Saudi Ophthalmology Society for organizing these scientific meetings, and special thanks again to Dr. Ibrahim Al-Jad'an, who is the head of the Saudi Glaucoma Group, for supervising us and sharing with us his experiences always. So my talk is not merely the challenges and the complications, but maybe share with you some difficulties that we are facing on a daily basis in the OR. So I will share my screen and all right, so this is the first case. She's an old lady. She's one-eyed and known to have an advanced angle corneal glaucoma. She's pseudophakic, and she has no previous glaucoma, surgeries, and she was really uncontrolled on a maximum tolerated medical therapy. So the plan was to go for Ahmed implant. This is her vision, and this is the pressure, and she has a very thin cornea. On examination, she was ortho and quite mobile conjunctiva, clear cornea, and even quite an EC. The angle was really zipped up, and she is having very advanced cupping. So the plan for her age was to go for Ahmed implant, and I jump or skip the trabeculectomy because I feel that in this age, the trabeculectomy is more complicated and have more challenges in such ages. So maybe to go for a safer Ahmed implant and maybe to ligate it if we want. So this is the glaucoma, the Goldman visual field showing the superior arcuate defect. So the plan, as I said, we go for Ahmed implant. So it was an eventful surgery as usual. It is usual simple cases, but the shocking thing at the day one, the vision was dropped to counting finger. The pressure is acceptable in this range, and the AC was completely flat. And fortunately, the reflex is good. And B scan, we did B scan at the day one. It was within normal, and the tube and the plate was covered nicely with intact sutures without any leak. So I was worried that this is one-eyed patients, so I preferred just to observe for one day, and then I didn't hesitate to bring the patient to the OR. This is the first photo for the patient at the day one. As you can see, I put the tube in the sulcus. It is almost touching and sandwiched between the cornea and the IOL. The IOL itself is pushed anterior to the cornea, and there's almost no AC at that moment. So this is another photo, and this is the UVM showing the flat AC with the anterior rotated ciliary body, and the IOL is almost touching, or there is no AC at all. This is the slit lamp photo of the patient showing very shallow AC. So the plan to go for OR, I bring the patient directly to the OR just to reformulate AC and to ligate the tube. Actually, I have a couple of patients, I experienced them to have malfunctioning valve. So I put this differential as the first differential diagnosis on my list, and my second is the aqueous misdirection. So that's why I bring the patient to the OR for tube ligation and to reform the AC and observe the patient afterwards. So it was very difficult to introduce inside the AC because the AC is almost flat. So I go with a 30 gauge needle with a Provisc, and as you can see, it's hardly to introduce the needle. It touched the IOL, but fortunately at the end, the AC formed with difficulty, as you can see, because there is a positive pressure. And I just incise the area and do paracentesis over the area of the tube itself, just in order to pull out the tube and ligate it with the Prolene suture. So with this positive pressure, I found that it is very impossible to proceed with this shallow AC. I found that it is mandatory to go with the vitrector to the vitreous or the anterior hyaloid face, just to disrupt the anterior hyaloid face or to debulk the vitreous in order to reform the AC and give chance for the AC to deepen and to do AC reformation. As you can see, just with the slow cutting rate, and as you can see, the AC is deep enough. With the micro forceps, I introduce the forceps in the eye and pull the tube out. And with the 9O Prolene, I ligate the tube completely, and I make sure it is 100% ligated and secured. And then with the same forceps, I put it back to the AC safely, and I remove the vitreous, the viscoelastic material from the AC. And then air bubble inside the AC just to reform and to close with the figure of 8 9O nylon. So this is the first case. The day one was, the AC was nicely deep and the pressure is almost 20 and above, which is expected. The vision almost, it was 20/50, and then at the day one was 2300 because of the corneal edema. I induced epithelial defect, and the patient was on bandage contact lens and with this astigmatism. So everything was accepted and reasonable. So I open the floor for any question or comments regarding this video. And if you want to share with you another video, I will go with it. What do you think, guys?
So have you made any stenting in the tube before you ligate it or after the ligation, Dr. Ali? I cannot see that you did any stenting in the video.
No, just ligate from outside with a 9O Prolene, and there is no stenting. I did not put any stent inside the lumen because there is no need, because I just suspicious about malfunctioning valve, which is one of the possibilities. But I found later on this is mainly aqueous misdirection, which is relieved by the vitrectomy and the IZH, which I did.
Okay.
Yeah, Ali, I just have one comment. I think you did a really good, great job, Yani. I just have one thing to say. You tackled 2 points together. So we don't know which one is working. If you close the tube and it's already malfunction, and you did a vitrectomy to release the aqueous direction, then you tackled 2 points. To know if it's over filtering, I think if we look far behind the plate, we would have seen a more type of a blip. Or if you did a UBM and you check the plate that it's over filtering, then we can know that there is a malfunction. But I think يعني all your picture were going towards the aqueous direction, even your UBM, I think.
Agree with you. Like, given the patient is one-eyed and old enough, and I'm not, trusting the ciliary body, which is always sick in such patients. And I would just want to give the patient a chance, or the plate a chance, to encapsulate. And it's just easy to go and do argo laser suture lysis to the tip of the tube and release this Prolene sutures once the IOP getting escalated with time. So just to make sure and be cautious, extra cautious in such eyes, to tackle both elements of diagnosis. But I agree with you. This is just extra cautious things. But the main differential is the aqueous misdirection for sure, after I discovered this intra-op. And the second is maybe the malfunctioning plate, which is not the issue at this moment.
Really great job, Ali, about the surgical technique and everything. I do agree with Ahmed about there are a couple of differentials over here. Malignant glaucoma would be on top of the list. I would put a malfunctioning tube a bit last, because there are other factors that could cause shallow chamber as well. You could have an overfiltrating implant, or a hyposecretion or cellular body shutdown. She's old, she's in her 80s, advanced glaucoma. So that's also one reason. It's very difficult to tell, as Ahmed said, which treatment actually resolved her issues. But I would think it's the malignant glaucoma most on top. I mean, she was pseudophakic and still with zipped up angles. It's likely that she's prone to get malignant glaucoma. I'm wondering if you usually fill your AC when doing an Ahmed valve with viscoelastic.
Yeah, I filled it in all Ahmed implants, unless the implant is ligated. So
okay,
most of them should be filled with at least Provisc, or maybe air.
So Ali, if aqueous misdirection was excluded from that case, or let me speak about another case. So what's your technique usually to diagnose an overfiltering tube?
So why the overfiltering or malfunctioning valve is one of my list is the pressure. The pressure is almost 10 or below, which is, more or less against the aqueous misdirection. Yes, it can be, like, it's not, common. Like, I put it in the differential, actually. So the technique is just to pull out the tube and ligate it with the Prolene 9.0. Sometimes you can ligate it with a 6.0. It's okay. And sometimes we can put a stent inside if we are suspicious, or the patient is high risk to develop hypotony. We can put a 4.0 nylon inside the lumen and put an extra Prolene outside the tube.
Yeah, just one comment regarding this technique, which is inserting intraluminal suture. I tried it with one of my patients who had an Ahmed implant outside, and he presented with a hypotony. So I tried to do this technique, which was described before by an Iranian surgeon, Ziamak, I think Zanavati. And his technique is to insert a 5O nylon intraluminal and keeping part of that suture under the conch. So in case if the pressure builds up, then you can just take it out later on. Honestly, for my case, it worked for just 2 months, and then the patient unfortunately had the hypotony again, so we had to ligate the tube again. So any further comments?
And I mean, the tube tip ligation is very important and very easy if the patient is cooperative enough, and the view and visibility to the I mean the sutures is good to lyse it later on. This is very important things to consider before doing this. Otherwise, you can just open the area and do a peritomy and do vicryl sutures behind the insertion.
Yeah, and always remember that ligating the tube alone will not 100% occlude the flow. So in order to have 100% occlusion, maybe you need to put intraluminal suture stenting inside, and then you just ligate with another suture. Okay, shall we move to the next case?
Right. So
We have a few of the attendees, they would like to ask you some questions here. Can we allow Dr. Saad al-Shomrani, please?
السلام عليكم.
Alaikum salam, Dr. Saad.
Dr. Ali, thank you very much for this nice presentation. If I suspect hypotony and he's one-eyed patient, why didn't go for transconjunctival suture like 8O vicryl? Because he's one-eyed patient, you give him the trial of suturing ligating the tube from outside. Maybe you can try 8O, put two suture and see if it's work. That would be good. If not, yes, I will go for the same what he did. I think sometimes when you put the tubes and it's move and you try to pull the tube, sometimes it detach tubes from the plate itself and it cause leaking. So I suggest also when you, especially you are a training center, some of the residents, they pull the tubes and it detach from the plate. So now when I fix the tube, I examine again the plate, I flush, I see if there is an leak from the junction, I change the tube completely. Thank you very much.
thank you very much, Dr. Saad. Agree with you, but I don't have an experience of transconj vicryl sutures. I found that this is maybe the easiest way to pull out the tube and just ligate it and put it back. The thing with detach the tube from the base of the plate, I think it's a good thing to consider. But fortunately, I don't have any experience with this. So thank you very much, Dr. Saad, for this.
I think there is also another common reason why you would have overfiltration. You would have a peritubular flow from the canal, like the scleral canal. Sometimes what happens if you create the scleral tunnel, you inadvertently expand the tunnel, so you get peritubular flow the first few days until it heals up. So this is one important thing to consider as well.
Right, agree with you. But just to tackle this and to make sure this is not the issue, you have to examine the area around the tube itself, and you can experience any blip behind the limbus. This is maybe the issue. So this is a good point to consider.
We have another request from Dr. Iman Al-Hussein. Can we give her the floor to speak, please? Dr. Iman, would you like to ask anything or to comment?
I think she has to unmute.
Yeah. If you'd like to ask, just unmute yourself, please, Dr. Iman. Okay, no problem. Then maybe it just was a mistake from her side.
Right.
Ali, would you like to go for the
So the second, let's go to this. This is 3-year-old. Is it obvious to you?
Yes.
So this is 3-year-old boy who presented to the KKISH ER at the age of 2 months. The parents noticed this, external appearance of the eyes, and they bring the patient to the ER. He actually followed with the PDA for 2 to 3 months, and referred the patient to us at the age of 6 months because of the high IOP, obviously. So on examination, as you can see, the cornea is opaque on both eyes with significant panos formation. And as you can see here, there is an element of aniridia with rudimentary iris tissue adherent to the back of the cornea. And again, on detailed examination, we didn't find any crystalline lens at the same time. So this is exactly bilaterally. And as you can see, the view to the posterior segment is not that good. So we did UBM at that time. We found that really the lens is not there congenitally. And the ciliary body is almost flat and atrophied. So this is actually identical in both eyes. And the posterior segment is within normal by V-scan. VEB showed a good response in both eyes. This is in January 2018. And genetic testing showed nothing or uncertain about the PAX6 variant. And we're still suspicious about aniridia and the variants. So this is the timeline of the patient's journey around, maybe 3 years now. He presented with this pressure, and he underwent serial frequent cyclodestructive procedures along the journey of this. Why is that? Because I believe that this kind of patient is high risk to develop complications. One of them is retinal detachment. The second is suprachoroidal hemorrhages and choroidals, and many things can happen if we did any invasive surgery, given the patient is aphakic and the eye is anomalous. So I bring the patient to the CTR sometime in this timeline, and again they confirm that you have to go with only cyclodestructive procedures and avoid any invasive surgery because it carries a lot of complications if you go with that. So I follow the commands and CBC done to the right eye at the beginning. And as you can see, the pressure respond at the beginning, then go back and respond after the procedure, then go back up. And the only thing we can do in such eyes is to go again and again for cyclodestructive procedures. So until 2 years back, we just shift from the traditional cyclophotocoagulation to the micropulse. And we just be cautious, as sometimes we did limited thing, but again, the pressure is not responding again to any procedures. At the last year, the cornea developed band keratopathy and EDTA done from the anterior segment side. And I found that we are repeating ourselves. We have to do something for the patient because he is deteriorating with time and the axial length is progressing with time. And I found that we have to counsel the family and to sit with them and to do something else. So I sit with them and I discussed the case, and we agreed that we have to do an Ahmed glaucoma valve with the help of retina colleagues, just to see if we can do any implants in such eyes, because as you know, the vitreous is everywhere. We have to explore the eye first by the endoscopy and see if we can do as a first line treatment to go for ECP, we can go with that. Otherwise, we can go for BBV to clean up the eye and to introduce the Ahmed implant. So they agree with me, and we consent them and we proceed with that. So this is last month. So at the beginning of October, it is this month actually. And as you can see, the axial length over time and for the right eye is becoming elongated with time. So that mandates us to go with the invasive procedures. So this is again the flash PEP for the right eye before going to surgery, just to make sure there is a, visual potential. And this is just an overview of what we can see. So we start the procedure with the paracentesis. It's very difficult to localize the limbus because of this aggressive pannus formation, and very difficult to say where is the limbus exactly. But roughly we can go with the, paracentesis from this area, and we introduce the endoscopy. So as you can see here, we don't find any ciliary body, even with the, exploration, and just we can see now the atrophied iris and atrophied ciliary bodies, and some areas of explosions from the previous ciliary photocoagulations. And another paracentesis done, and we found just maybe 1 clock hour there, as you can see here, which is very flat and atrophied ciliary processes. And again, we realized that this is not the ideal thing to go with only ECP. We have to go for major thing. So thank you, Dr. Sulaiman, just to join me to do the pars plana vitrectomy to clean the eye. And we agreed that the pars plana introduction of this trocar is not the ideal thing. We have to go with the anterior approach just to avoid any risk of retinal tear, because again, we are not 100% sure about the pars plana area. So anterior approach, pars plana, as you can see, trocars in place, and he did very good job. He did very good job, صراحة. لكنه even he used the endoscopic, ECP probe just to visualize the anterior chamber area and to clean up the anterior segment from the vitreous strands. So he ended up with this, and he completed his vitrectomy. We closed the areas of sclerotomy, and we started the implant. So by dissecting the area of implants, actually it is very tough to to put the plate, because we want the plate to be as posterior as we can, and to be at least between the lateral and superior rectus. After fixation the tube, and we made sure that it is in place and doesn't move with time and with manipulation, we introduced the 25 gauge needle roughly just posterior to the limbus, and we introduced then the tube to the eye. It is maybe roughly pars plana, or at least at the area of ciliary body, but at least it's beyond the limbus. So as the eye is aphakic, we have to keep the infusion on all the time, just to avoid any risk of collapse or any complications. Double layer of tutoplast is there, and I found that it is very crucial to ligate the tube. So I ligated with a 6-0 vicryl, and just to avoid any risk of complications. And I think that I have to put one more just to avoid any complications. So 2 6-0 vicryl ligations in the tube, and then I covered the tube with this tutoplast, and the rest of the procedure went uneventfully. So I closed the conjunctiva with 9-0 vicryl, and again, if we want to remove the trocar or the infusion line, we have to close the area, because as you know, in children, the leaky wounds is very common. We have to ligate. We have to close the wound of the infusion. So very special thanks to Dr. Suleiman and to Dr. Badr Al-Hazza, as he is the first assistant to me. So I'm ready to receive any comments or questions.
This is excellent surgery, Dr. Ali, as usual, and such cases need, good teamwork between glaucoma and retina people, because the more they understand the case and the more they can help and participate with their opinion and management, the better will be the outcome, of course. Ahmed and Ala, any questions or comments from your side before we proceed?
Nice job, Ali. I couldn't agree with you more. Your management was on the spot. So, like, I agree with you that additional CPC or cyclodestructive procedure would not help, and totally agree with what you did. Probably I would have thought another option, maybe a Barvelt. I don't know if you considered that option, since you're going to be ligating anyways, and maybe likely you would have better success, less encapsulation compared with an Ahmed.
Actually, it's off my table because the Verbal implants is non-bulk, and this is a risky eye with aphakia, multiple cyclodestructive procedures, and as you can see, maybe this is the seeing guy. We didn't do VEP at that time to the other eye, so we are not gambling here. We have to be very 100% sure that the tube is functioning, I mean, in a staged way. So we have the ligation, we have the valve, and we just nastawda Allah.
Okay, thank you so much, Dr. Ali, for those excellent presentations and videos. For the sake of time, we'll just move to the second presentation. We have Dr. Ahmed Al-Habash, who's an assistant professor of ophthalmology, glaucoma and cataract consultant at Imam Abdurrahman bin Faisal University at Dammam. He's going to move to another field of interest. He's going to speak about some of the MIGS. So his video is going to be about what can happen with ab interno and ab externo canaloplasty. Dr. Ahmed, please go ahead.
Thank you, Dr. Ahoud. And I would like to thank also the Saudi Ophthalmology Society and the Saudi Glaucoma Group. It's nice to be again together all. I would like to apologize if my voice is a little bit rusty because I have a little bit of an upper respiratory tract infection. I think it's difficult to present after Ali's special cases. So regarding, I'll just give you a little bit brief about canaloplasty and the idea. We're going to talk about it more. We'll go through the first case that I had. So we had a 58 years old female that had advanced primary open angle glaucoma, and she's on full topical medication and also on systemic Diamox. Her vision is 0.2 and 0.6, pressure above the target, early lenticular changes with an open angle and advanced cupping with severe visual field defect. So I said, let's do an right ab external canaloplasty with a deep hysterectomy. So just to know that usually what we do in ab external canaloplasty, we do the regular conjunctival peritomy, and then we do a superficial flap, then we do the deep flap. We cut the deep flap. If you would like to peel the Schlemm's canal, and then you go with a catheter. So for the sake of time, I'll just go for the catheter. We go with a catheter in the Schlemm's canal, and as you can see here, I catheterized the canal 360. And after that, as you can see, usually what we do here, we have two options in the ab external canaloplasty. It's either that you suture the other end with a proline, and you go from the other end and you stent the canal, or you just go with you just retract the catheter and you start injecting viscoelastic while you are retrieving. So the recommendation here from the company that has been long time ago is 2 clicks per clock hour while you are retrieving the catheter. So as you can see here, while I'm retrieving the catheter, I think I jumped directly to the problem here. While we are injecting through the canal, we had here a decimate detachment. I'm not sure if it's really obvious. So in the literature, there was like 5 or 7% from the apex stenocanaloplasty decimate detachment. And there is another also complication, which is the intracorneal hematoma that has been described from some of our colleagues in King Saud University also with the apex stenocanaloplasty. So what I did here, after I noticed the decimate detachment, and then you can see the blood coming as a reflux from Schlemm canal. So I closed the scale flap as usual, and I closed the conjunctiva. Then I start washing the blood clot with a regular Semco. And then I injected some viscoelastic just to tamponade this blood because I don't want it to go inside the canal. As you can see, still I have this decimate detachment. I opened another place, just try to relieve the deciments. Then I went again, try to wash, and as you can see, this is a phakic patient, so it's a little bit tricky. So my plan was here is to inject in gas, just try to tamponade this decimate detachment as much as possible. The problem here, it's a bit inferior, so it's more tricky because when you inject air, usually the air goes up. So if you have a superior decimate detachment, it would have been easier. But with an inferior decimate detachment, it's a bit more difficult. And usually with canaloplasty, most of the detachment are inferior because of the viscoelastic that comes as a gush, mainly is accumulated in the inferior part. So I tried to inject here, but still there is viscoelastic. I washed a little bit more of the viscoelastic to give a space to inject the gas. And after that, I injected the gas. The decimate was in, as I can see, it's not in a bad position, but still I have a detachment. But this is what maximally I can do with this with case. So the first day post-operatively, as you can see, this is the bleb. The gas is here. The decimate detachment is inferior. I try to play with the positioning of the patient, try to tell her to lift up her head. You can see here the decimate detachment, and in the other picture also. Again, this is the decimate detachment. This is all the area that the viscoelastic was injected from the Schlemm's canal, because as you know that the Schlemm's canal is the termination also of the decimate membrane. To be honest, I still don't think that 2 clicks per clock hour is the right option, because we know that each the Schlemm canal is different than the other, and the size of the Schlemm canal. So with the viscoelastic going up, it might disrupt this decimate membrane. This is also the anterior segment OCT. You can see here the decimate detachment first day post-op. I rebubbled the patient also. After that, 2 weeks post-operatively, the patient did better. The cornea started to clear, but still I have a little bit of small decimate detachment. I consulted the cornea people, and they advised that this is fine and it does not need further intervention. We saw her 1 month, cornea got clear, and everything went fine. But what I could have done more different in this case, and what I've learned from this case, is to decrease the amount of viscoelastic injection while I'm injecting the catheter, pressurize the eye more to try to create a resistant area that would prevent this detachment. Other thing is the problem here is we have already a viscoelastic in the anterior chamber. So trying to attaching the dissonant membrane may be difficult because you have the hyalon or the viscoelastic in between the two layers. So what the cornea people taught me that you might do fenestrations from the epithelium to full thickness, that this might relieve the viscoelastic. So this is the key lessons that I understand it from the ab externo canaloplasty, and this can happen during surgery. So I think I will go to the second case because of the sake of the time, and then we can do the questions and answers. The second case is a 61 years old male, known case of primary open angle, with a vision of 0.1, 0.2 on maximum meds, significant cataract, open angle with a moderate to severe also cup disc ratio. So I decided to go for a phaco plus IOL plus ab internal canaloplasty this time. So it's an ab internal technique with gonio-assisted transluminal trabeculotomy under local anesthesia. So I did a quadruple surgery because I wanted the pressure to go down, but with minimal risk. And this is what we described earlier this year, our technique in combining these procedures together. So this is just an animation of what is an ab internal canaloplasty. It's a very quick video. As you can see, this catheter goes in the canal through the goniotomy that we do in ab interno, and we inject viscoelastic, the same as ab externo, but this is ab interno without releasing any cutting any conjunctiva. And you can see we inject viscoelastic to try to dilate the canal or to open up any herniation in the canal. And the gonio-assisted transluminal trabeculotomy is when we rip the catheter after we finish the catheterization. So this is the video of the patient after doing the phaco. I'm not getting a good the video of the phaco. So as you can see, we catheterize the canal, and while just wanted to see here, we're catheterizing the canal, and we're injecting viscoelastic simultaneously. And as you can see, if you saw it here, you can see the decimate detachment while injecting in the canal. I think it's obvious how the decimate rips off. So to be honest, I continue catheterizing the canal with very slow injection of viscoelastic. I decreased the amount this time until I reached 360, and then I decided to go with the GAT procedure. As you can see, I ripped 360 trabeculotomy with the catheter, using a very careful technique, because I already have a decimate detachment here. It's like a semicircular detachment. It's a little bit superior this time because it's a different approach. I try to tamponate it with viscoelastic, try to raising it up more before having the blood reflux of Schlemm canal. Then I decided to clean up the viscoelastic and tamponade it. As you can see, this is the decimates. You can see it floating in the anterior chamber, and but it's going up. And what's nice about it, that it's superior. So this is what's different in this case, that you have a superior decimate detachment, which made my life easier. So I decided to inject air bubble this time, not gas, because I know that it's superior, and air bubble can be enough, and try to pressurize the eye even with viscoelastic under the air bubble to prevent any blood reflux and going through the membrane and causing more problems. So this was in the end of the case. I sutured, and the viscoelastic tamponaded the decimates. It's, as you can see, it's attached. I did also intraoperative OCT, but it's not here in the video. And this is the OCT first day post-op. So the decimate membrane is attached. So I would like to thank everyone, and if anyone have any question, it would be my pleasure.
Thank you so much, Dr. Ahmed, for the excellent presentations. Now, let me ask you a different scenario. Now, if the site of the descimate detachment was different, would that, make it different for your approach? So do you change the approach depending on the site of the descimate detachment?
Yeah, you mean inferior superior?
Yes.
That's what. Yeah, inferior is more tricky. This is the problem. As we said, that the gas or the air bubble would be difficult to tamponade. Maybe this time I would have sutured it. I would have thinking of suturing it, to be honest, and tamponade it at the same time. But suturing superior is more forgiving, and you can do gas or air bubble tamponade. But I think suturing inferiorly is a better option.
So one more question for your first case. Now, after you injected the gas, suppose that you have an overfilling, okay, of the gas. Do you think that would lead to sort of collapse to the Schlemm's canal, and that would have an impact on the post-operative pressure later on?
It might be, but because I did a combined deep sclerectomy canaloplasty, this helped me more. And in the first couple of days, the pressure is, first 2 days, the pressure was above 35. But I just wanted the deciment to attach. This is where you have the two things, the risk and benefits. Do you want the deciment attached, or you want the low pressure? So I decided to have a deciment attachment and just observe and put him on oral Diamox until and now she's off medication with a better. But the first 2-3 days it was a hassle.
Okay. And we have one question from Dr. Nasser Al-Saadi. For inferior descimate detachment, how would it be if you use perfluorooctane instead of gas injection? So what do you?
I have no idea about that, you know. If he was beside me, I would have asked him. If I have a written, maybe it's a good idea, but I'm not sure. I didn't try it in the anterior chamber.
Any different thoughts from Ali or Ala?
Thank you very much for these kind of tough cases. That's why I'm not a fan of ABICS. So maybe GAT is more benign for such patients. What I mean, wondering if you do like a full thickness corneal incision at the area of decimate detachment just before tamponading the area of air or whatever, just to create an outflow of the viscoelastic material out of the eye, and just tamponade and let them go out of the being between the decimates and the stroma. And if you tamponade it without any outflow, this is useless. Maybe I guess.
Yeah, I think so. That's what I was talking with the cornea people, and this is what they used to do in the DASIC, in the beginning of the DASIC. They used to do a full thickness to have this in the beginning of their procedure, and then they started to do different things. But yeah, I totally agree with you.
Okay, so thank you so much again, Dr. Ahmed. We'll move to the last presentation. We have our speaker, Dr. Ala Mufti, who's a glaucoma and advanced anterior segment surgery consultant at King Abdulaziz Medical City at Jeddah. Dr. Ala just came back from Canada. He was having his fellowship with Dr. Aik Ahmed for 2 years. So, Ala, I'm sure you are missing the nice hot weather of Saudi Arabia. I'm sure of that. So, welcome back. Dr. Ala is gonna speak about things that can happen with simple cases and how he managed the post-op complications. Please go ahead, Ala.
Thank you very much, Dr. Ahoud, and thank you for the Saudi Ophthalmological Society and for the Saudi Glaucoma Group for having me to speak. And special thanks to Dr. Al-Jadan for the initiative. I'm going to start my presentation. It's a simple case. So this was a 48-year-old lady who had left mild primary angle closure glaucoma despite having a patent LPI. She also had a history of angle closure attack in the past when her eyes were dilated and the pressure went as high as 30 on dilating eye drops. She was on Blumigan and pressure was controlled. She was found to have lens rise and plateau iris on examination. And as you can see in the anterior segment OCT as well, she does have some lens rise. And you can even note that from the biometry, she doesn't have a thick lens. Despite that, she has a shallow chamber and a short eye relatively. So based on the presence of angle closure and plateau, we decided then on September 2019 that she should go for a phaco IOL and endocyclophotoplasty to address the plateau as well. So what happened was she showed up on post-op month 1 and she had developed signs of malignant glaucoma in the left eye. She came with a flat AC and shallow eye. She's from another province, so her local doctor at that time diagnosed it and informed us. And she underwent a YAG iridozonular hyaloidotomy, which didn't resolve it completely. So she had to be stuck on 3 classes of glaucoma medications and Diamox and atropine to kind of have things controlled. There have been several trials to remove her from medications, but she keeps going into malignant glaucoma attacks. On examination, she has 270 degrees of peripheral anterior synechia. And in addition, she had developed that atonic pupil, which was large in size. Even after cessation of atropine, because of the extensive peripheral synechia, it didn't resolve and the pupil remained dilated. And she had positive dysphotopsia and she was really bothered from the light. So she didn't follow up with us for a long time because of COVID. She couldn't travel to Ontario and come to our clinic. So we saw her something in like August. And this is when we decided to go for surgery and to address all of her issues. So we had to address the malignant glaucoma and her atonic pupil. So we decided to go for a iridozonular hyaloidovitrectomy along with goniosynechia and an iris cerclage to address the pupil. So over here, we're starting our surgery by doing multiple paracentesis incisions in order to assist me in injecting viscoelastic and to prepare for the iris suturing later on. Doing the main incision over here, I'm injecting some lidocaine and then viscoelastic. And I want you to notice that when we overfill the eye with viscoelastic, it doesn't deepen as much and you get burping of the viscoelastic because of the malignant glaucoma. Here's an operative gonio, which shows that the angles are fully closed and with high synechias in some quadrants. So I go then with the 23 gauge vitrector and I go superiorly. I choose an area where I put the cutter on the peripheral iridectomy mode and do a peripheral iridectomy. And I don't know if it's very obvious over here, there was a little bit of deepening of the chamber that happens when the iridectomy is complete. So that's the first step. I did a large opening. Then I go from the main wound. And because if the eye is filled with the viscoelastic, I don't need the infusion. I go in and I push the rod inside so that I can pierce through the iridectomy and go through the zonules and start cutting with the vitrector. And this is how I do my iridozonular hyaloidovitrectomy and in effort to make the eye as a unicameral eye. And once I'm done, I fill the eye. You can notice how significantly deeper the eye becomes. And then if I look at the gonio again, the angles are now much open. Now I found this quadrant where it had some synechia, so I used a micro grasper, kind of pull the peripheral synechia away from the angle to kind of establish a more open angle. Okay, I'll skip to that part. And then after that, I moved to the next part. The reason why we were doing the pupilloplasty afterwards, so this is just to show that where it's all open. The reason why we're doing the pupilloplasty is for two reasons. So number one is to address the positive dysphotopsia that the patient is complaining of. And the second thing is that the pupilloplasty will also address the angle closure because you're stretching the iris away from the angle. And you can notice after injection of Myocol, the pupil is still not constricted significantly enough. And this is why we have to do the iris cerclage. So I start off by stretching the iris as much as possible to kind of get a feeling whether if you have a redundant iris tissue or a atrophic tissue. So this tells me if I can suture it or not. And overall, it looks great. It looks like this is something that I can suture. So then I go to the next step. I'm using over here a 10-0 Prolene suture on a CIF4 needle. It's a long curvy needle. And I pierce at one area of the iris, and then in a baseball mattress pattern, I keep feeding up the iris tissue to the needle. I try to make my needle hand stable as much as possible, and I loop around the iris tissue with the other hand. The aim over here is to get as many bites as you can along the thread of the needle so that you get a more regular and cosmetically appealing iris. And at the end, I use a viscoelastic cannula to dock the needle so I can remove it safely from the eye without going through corneal tissue. Otherwise, you get the suture thread stuck into the corneal stroma. And this will be a big problem. And I'm using my viscoelastic cannula here to counteract the iris movement so that I don't end up with an iris prolapse. I go here from the other side. I do the same thing exactly. Okay, this is a double arm needle. So I've used one arm to suture one side, and then I went for the other side with the other arm. I'm gonna speed up a little bit. Okay, now I was done with the supranasal and supratemporal quadrant. I go through the paracentesis over here, and I do the emphrotemporal, then the emphronasal, and I dock through the main wound incision. I'm gonna make it a bit faster. I'm retrieving the needle over here. Then the same thing over here at the last quadrant. Okay. And yeah, retrieving the needle for one last time. And this is when we tie up the suture. And basically we do a 3-1-1 with an intraocular tying technique where I do the knot externally. Then I use a micro forceps to pull the thread inside the eye so I can tighten the suture as much as possible. And then we decide on what size we cut. So we aimed for a 3mm pupil. It's sufficient enough to kind of address the symptoms for the eye. And on the other hand, it allows us to easily examine the fundus if necessary. And over here, I'm locking the suture. You can see some pigments over here. This is why the view is not clear of the knot. But you'll see at the end how it looks like when it's done. And I'm locking it over here. Okay, so I've locked and cut the suture already. I'm hydrating the eye. And I've placed the suture through this wound. And in the end, ended up with a deep chamber dye with a iridozonal hyalodo vitrectomy performed and a cosmetically acceptable pupil and no longer a 5x4mm. And that's it for my case. So.
Thank you so much, Dr. Ala. Very talented video and excellent presentation. So I have a question regarding the iris cerclage. I don't have a good experience with complete cerclage. So after the procedure, it looks cosmetically very beautiful, but how do those people respond to Mydriatics later on? If we need to start them on Mydriatics, dilating the pupil if they are diabetic patients, so how would they respond?
Yeah, that's a good question. So because most of those patients who get a cerclage, they are usually atonic. They don't dilate from the first place. So for example, this patient, when you saw her in the beginning of the case, she didn't have any dilating drops. She was dilated just as like this naturally after her glaucoma. So you can dilate them. Actually, they always are examined, either with an Optus camera, for example. Like there are cameras that can actually get a fundus photo, full retinal exam, or you can just try your best and examine with a 90 or a 78. Now, in the future, let's say someone is diabetic and needed to go for surgery. Let's say a retina surgeon needs to operate. They can just simply cut one part of the suture and pull all the thread, and the pupil can be expandable again. They can call us again and redo the cerclage. Like, I haven't seen that scenario, but technically that's possible.
Okay. I know Dr. Ali also, he did few of those cases, the IZHV. So my question is to both of you and to Ahmed, if he has an experience as well. What's the best way to go for that? Is it the corneal or through the ostium or pars plana? Just tell me from your experience.
Yeah. So I think the best part is whatever the surgeon feels safe for. Oh, sorry. Go ahead, Ali. Ali, you can go. Okay. I think the safest, whatever the surgeon thinks it's safe, should go for. Some surgeons are comfortable going pars plana approach and others anterior. We try as much as possible to go for the anterior approach because it's the safest overall. But ultimately, it depends on the appearance. Like this patient, for example, the chamber was like shallow, but moderately enough for me to advance the vitrectomy port through the anterior chamber and do it. If this is like a really collapsed eye, like the first case that Ali presented, I think this is a good case to go for a pars plana approach, 3.5 millimeter behind the limbus and do it.
Yeah, interesting. Dr. Ali?
Yeah, for the couple of cases I did, most of them with the posterior approach. So the one I presented, it is a limbal approach, just go through the iris directly through the zonules and back to behind the IOL and do the vitrectomy. But make sure you have a unicameral eye and a very large pupil, just allowing the eye to avoid any accumulation of the vitreous behind the IOL. So both are possible approaches. So as Dr. Ala mentioned, which approach is you are comfortable with.
And do you all guys give the patient intraoperative mannitol?
I did actually. All have to do it, and it makes a difference actually.
Allah?
So not in every case. Like if it was a short eye, like I remember we had cases where we had patients with axial length less than 18. And for those, yes, we give mannitol preoperatively. But for this patient, if it's like a 21 and a half, and I don't think we needed to do mannitol for that. And I also want to stress, because I know some surgeons where they would think that you need to do a core pars plana vitrectomy, but I want to emphasize that the key thing in malignant glaucoma is the IZHV part. Even if you did like a complete vitrectomy, if you don't do a unicameral eye, it will not solve the malignant glaucoma. There are case reports in the literature where patients who had complete pars plana vitrectomy and still developed MG because they didn't have an IZHV.
True.
Right. So when you have an intact anterior hyaloid face, so the problem is just a vicious cycle of still it's going to happen every now and then. So if we don't disrupt the anterior hyaloid face, the problem is still there. So I agree with you. Doing this is posteriorly or anteriorly, but you have to disrupt the anterior hyaloid face, and sometimes can happen with the needle also. Other slit lamps sometimes can work with that.
Yes.
Any comments, Ahmed, from your side?
No, I totally agree, but I'm with the point that give mannitol. I did it with a couple of times.
With all cases.
Yeah, you give mannitol. It makes you easier when you go and you inject viscoelastic. You will find some space, So you can go anteriorly and do your small PI with the whole vitrectomy IZH. So I think it gives you this space that when you inject, you can go with your vitrector. It makes your life a little bit easier to monitor.
Okay. Ali, do you have any of those cases ready you like to share with us?
Yeah, no problem. So let's
Okay,
go.
yeah, please go ahead.
All right. So this is an old lady who is presented with chronic ankylosing glaucoma and controlled on maximum medications. Actually, she developed aqueous misdirection to the other eye and she lost it after a complicated cataract surgery. And this is her only eye. So after trabeculectomy, she developed aqueous misdirection, as you can see in these photos. So the AC is shallow, and as you can see, the angle is totally closed. And we wait for laser and treatment by cyclopedia for, good amount of time. But I think at the end of the day, we have to go back to the OR and do the ICH thing. So given the patient is uncontrolled, after trabeculectomy, we suggested to join the retina people to go with the Ahmed implant at the same sitting. So we, at the first, at the beginning of the procedures, we just fixed the plate. And after that, let me speed up thing. So the retina colleague is start doing the pars plana vitrectomy. He did the complete pars plana vitrectomy, and this is 3.5 millimeter behind the limbus, which is the future opening of the tube at the end, and then complete vitrectomy done. And then we did lateral or temporal paracentesis here, and with vitrectomy we go with the vitrector, dry vitrector actually, and go behind the IOL through the iris and create a large opening just to disturb or disrupt the anterior hyaloid phase. And then after that, and we go with the posterior approach from the other side and make sure the opening is completely open. As you can see here, see the vitrector opening now. We are enlarging the area of the IZH opening. Make sure the eye is achieving the unicameral status. And then we close the area of opening. And then after removal of the trocar, we introduce the tube from the same opening. It's considered pars plana opening and insertion. And as you can see here, you can notice the tube is visible and visual access. And then just to make sure it is free of vitreous strands and in a good place, we just visualize it by Dr. Robio at the time. So it's free of any vitreous, and we close all the wounds. And then we ligate the tube again. And we cover the area of the tube with a double layer of Provis. And then goniosinic lysis done at the end of the procedure, just to establish any remaining outflow of the eye. And we have to remove the viscoelastic from the eye because the tube is already ligated. And after we hydrated the wound, and this is the picture of the case pre and post. This is the UPM. As you can see, the AC is too shallow, and this is after we did the procedure. As you can see, the angle is open and the AC is deep enough. The patient is happy, and the AC was beautifully deep. And the vision actually improved because, you know, the lens is becoming in its natural place. Again, you can see the ciliary body is becoming back and the AC is deep enough. And here, as you may notice, the AC is deep and everything will go to the baseline anatomy. Thanks, that's all what we have.
Very interesting, Dr. Ali. Dramatic difference before and after the surgery. Thank you so much. So for those cases that you had to ligate the tube, did you need to laser the ligating suture in any of these?
Actually, the last one is with Vicryl, which is behind, and it's covered already with the patch graft, so no way to laser anything. But the first case, I think we have to laser the eye because she is, developing high IOP with time. And I'm expecting the patient to come next week. If the pressure again is high, we have to go to the laser room and do argon laser suture lysis.
So for the second case, suppose that the pressure was, consistently high. What would be your next step?
خليك متفائل. It's not hard. ما هي سهلة لكنه
I'm just the other different, bad scenario.
Yeah, we have to
always, which we usually see in glaucoma, clinic.
Yeah, we have to wait at least for 2 months. We are expecting the Vicryl sutures to dissolve within like 6 to 8 weeks. But sometimes we have to wait more. So like this patient, I wait for 2 months, and the last visit, the pressure came down around 16. So the pressure was high for almost 2 months. So in case of the pressure is persistently high, I think if there is a high-risk patient or the risk of, wipeout, we have to go back to the OR and do cutting the suture.
Release it. Any further comments from Ahmed or Ala before we conclude? I don't see any questions from the attendees. I think we can just conclude right now. I would like to thank you all for the excellent, videos that you shared with us. Some of these were really scary. Like, if you are just preparing us for the Halloween, thank you so much, guys. So good job. Thank you so much for being with us today, and thanks to all the attendees. And see you, inshallah, in the next Glaucoma Saudi group webinar.